Okay, we're ready to get started. So thank you for joining us for this conversation with Dr. Ginevra Liptan and Dr. Andrea Chadwick. I'm Nicole at Swing Care, and I can't wait to dive into a topic that we talk and think a lot about: fibromyalgia and fatigue, improving sleep symptoms. We had a great discussion earlier this year with Dr. Liptan and Dr. Chadwick, and I'm so excited to welcome you both back for this deep dive into sleep. So thank you for being here.
My pleasure. Last time was so fun. I'm glad to do it again.
Absolutely. Thanks for having us.
Great. Well, before we dive in, I wanted to introduce both of you and give people a little bit more about your background. Dr. Ginevra Liptan is a graduate of Tufts University School of Medicine, board certified in internal medicine and trained in functional medicine, a holistic approach that blends both Western and alternative medicine. After developing fibromyalgia as a medical student, Dr. Liptan spent many years using herself as a guinea pig to find successful treatments and has fine-tuned her approach by treating thousands of patients. She is also the author of the Fibro Manual, a complete fibromyalgia treatment guide for you and your doctor. And Dr. Andrea Chadwick is medical director of Swing Care and double board certified in anesthesiology and pain medicine. Her clinical expertise focuses on complex centralized pain syndromes, including fibromyalgia, and she is the director of the Fibromyalgia and Centralized Pain Exploration Lab at the University of Kansas Medical Center. So the FACE Lab, thank you for putting a face on invisible illness. I love your tagline. And so to kick things off, I'm wondering, when we're talking about fibromyalgia, which is technically categorized as a widespread pain condition where pain is that primary symptom, why are we talking about sleep today? Why is sleep important?
Well, I'm going to let Dr. Liptan speak first because she has a wonderful chapter in her book dedicated to sleep. There's a lot that goes into it, but I'll have Dr. Liptan kind of provide a nice overview of it.
Sure. So you're right, Nicole. Traditionally, fibromyalgia has been thought of as a pain condition. And so, the first diagnostic criteria back in 1990 really only focused on pain. It really didn't talk at all about fatigue or sleep. But pain is not all that patients experience. I kind of think the trifecta of fibromyalgia is widespread chronic pain, brain fog and fatigue, and restless, not restorative sleep. I mean, poor sleep and kind of waking up not feeling refreshed is really such a cardinal symptom of fibromyalgia. In fact, if somebody comes into my office and I talk to them and I'm getting their history and they say they sleep great and they don't have any fatigue issues, then I kind of can almost rule out fibromyalgia and think, okay, let's, what kind of other pain condition might you be dealing with? And the newer diagnostic criteria, the 2016 kind of updated criteria, now actually also do include pain. They still include pain, but also now fatigue and non-restorative sleep and brain fog. So I think that we've actually made a lot of progress in our understanding of fibromyalgia as far as kind of getting that broader spectrum. And a lot of patients, actually, what's so debilitating to them is more fatigue and fog. I mean, that can make it really hard to function and stay employed. And so while pain is also such a huge component and a thing we really need to address, I have found that if we work on the kind of more underlying issue of sleep disturbance, we can actually get a lot of improvement in both pain and fatigue and fog. Do you find that, Andrea, that kind of if you work on sleep, other things can also get better?
100%. The sleep is such a big key piece of it all. And interestingly, it's, I'll treat patients symptomatically and they may have some fairly decent improvements in their pain scores, but they'll still report fatigue, brain fog, but also just really difficult times with sleep. And they're like, doc, I'm feeling better physically when it comes to my pain, but the sleep is still a really big issue. And I think it harkens this idea, I think previously with the 1990 criteria, they maybe recognized that sleep and other things went along with it, but they probably just thought it was related to the pain.
Right.
And what we know now about just kind of the underlying, mechanisms behind fibromyalgia is that the sleep and the brain fog and other, just really distressing symptoms to patients aren't necessarily driven by the severity of pain. They really have their own processes at play. So I would say, even though I'm not a sleep doctor,
Right.
not a brain fog doctor, I
Right.
have to address those in some capacity, which is obviously why we're here to talk about this
Right.
today.
Right.
But it's not cut and dry, like treat the pain, treat all of it. Like it's just not that easy. And
You're
so
totally
I'm
right.
really excited that we're going to dig in and identify more strategies to help people, whether they're pharmacologic or non-pharmacologic. But
Right.
yeah, it's I would say more distressing than the pain a lot of times for people.
I agree. I
They get
agree.
very concerned. Oh, well, do I have dementia because,
Right.
or, why am I like forgetting things? Do I need to see a doctor to see if I have, some sort of, dementia issue or
Right.
psychological,
Right.
neuropsychological condition? It's, I'll refer to people for help, such as sleep physicians and neurologists, but I still have to try and manage it on my own.
Right. I feel like if you're treating fibromyalgia, you do kind of have to be a little bit of a sleep doctor, and you're already double board certified, so you don't need to add another certification in there. I think you're good.
I mean, anesthesiologists do put people to sleep. It's just not the kind of sleep you want in your house.
Right. But you're kind of an overachiever, like, so you don't need another board certification. But I have really had to become very familiar with kind of sleep, normal sleep, and then kind of disturbed sleep. So the way that I kind of put together my understanding of fibromyalgia, both from kind of studying from the inside of my own body, but then also reading the literature and treating patients, is that I think the kind of main driver of the sleep disturbance is actually what I kind of think of as the primary driver of fibromyalgia itself. And that is that chronic overactivation of the sympathetic or fight or flight nervous system. And there's been some really interesting studies looking at, like heart rate variability and other ways that you can kind of measure the balance between fight or flight and rest and digest. And consistently in fibromyalgia, when they look at sleep studies, our brains are still in that fight or flight mode even while we're sleeping. So if you imagine your body is trying to keep you sort of somewhat alert because it feels like there's imminent danger. How are you going to be able to get into that deep, restful, restorative sleep? And sleep studies across the board with fibromyalgia show disturbed sleep, lots of different types of disturbed sleep.
Yeah.
And, not everybody shows it the same way, but there is this very interesting, what they call kind of alpha delta pattern, where you see these awake brain waves kind of superimposed on that deep sleep. And so the best analogy that I give to folks that don't have fibromyalgia, if you want to understand fibromyalgia sleep, remember the last time you fell asleep on an airplane. Like, you were kind of asleep, but you're still aware of like the flight attendant walking down the aisle. And when you woke up, you felt really just like groggy and like not rested and almost kind of worse. And then it kind of contributes
really
to
concerned.
Right. Right. Like,
am I okay?
Your brain is just like, what is happening? And to me, that's kind of what fibromyalgia sleep can feel like. So
that's a really great analogy.
Right? Because everybody's done that.
Well, because we've all tried to fall asleep on a plane, and you never get that deep REM, like blissful chef's kiss sleep on a plane.
It's terrible sleep. So if you imagine with fibromyalgia, you're getting that kind of sleep, like, what do we do to improve it? We haven't figured out a way to really improve permanently that balance between fight or flight and rest and digest in fibromyalgia. But if there's things that you can do temporarily to kind of calm your body before bed, whether it's deep breathing, meditation, listening to, relaxing music, having like a good bedtime ritual, taking a bath, all those things that trying to kind of get your brain and body in as calm a place as you can before you get in bed. And then I really like the term sleep habits. I don't like the term sleep hygiene because it sounds weird. Like, am I dirty? Like, do I have to,
I know.
right? I don't know where they got that, but having good sleep habits is pretty important. And I think a lot of us as adults sort of don't do that very well. Like, if you think about it, if you have a kid or, a puppy, like, you try to have routines at night, right? So you like, okay, now it's time to brush our teeth. Now we're going to take a bath. Now we're going to read a story. Now we got in bed. Like, we wouldn't give the kid like sugar, stay up as late as you want, watch a scary movie, have like a bright light next to you. all kinds of things that we do as adults, we'll have like stimulating to have glass of wine with dinner. Well, that's actually kind of stimulating and activating to your brain, watching the news, looking on social media, all those things that can kind of like, activate that. So I'm like, okay, pretend like you're a little kid and you're trying to put yourself to bed and like give yourself that bath and hot milk or whatever. And that has been also useful analogy for patients to kind of understand, because it's like, oh, right. Yeah, I need to actually try to engender a good environment for sleep first.
Absolutely. I also talk about how I think the bed has kind of become a place for like non-bed activities. I mean, I'm not good at following that myself. I oftentimes will like have a snack or a glass of wine in bed, while I'm watching a TV show, because I don't have a TV in my sitting room. So to put it in the bedroom and, or have a puppy on the bed. Like there's all these really activating things I'm doing in the bed. And I always tell my patients, it's like, when you look at a desk or kitchen table, like what activities you do in those places, right? So like if I'm actually filming this from my kitchen table, but it's the best place for it. But when you look at a desk, that's where you do work. Or if you look at a car, that's where you go driving. Why would you think a bed is like this place for this, just like a free for all? So
right. That's where you do your work, or that's where you eat yeah. But I think the pandemic really shifted. A lot of people moved in, or they were home more and just needed their own private space, and that became kind of the bedroom. So certainly within doing the best you can, I think, within the confines of your life. And so
I think if you're trying to improve it, that really taking that bed as this is where I sleep.
Totally. And then having good sleep habits. And then the other thing that I think is really important is from a kind of working with your doctor standpoint, other sleep disorders are pretty common in fibromyalgia. Like sleep apnea is much more common among women with fibromyalgia, even women that don't typically fit the normal criteria, what we think of, somebody that might be overweight or have like more soft tissue around their neck. What we see in fibromyalgia is that I've seen young, skinny women that I'm like, I would never think that you had sleep apnea, but maybe they're hypermobile. Maybe their neck kind of compresses when they sleep. And so I mean, if insurance paid for it, I would pretty much get a sleep study on everybody. Don't you think that would be so helpful?
It would.
I can't always justify it. So I really have to look at like, so I ask people questions like, do you nod off? Are you, yeah, right, exactly. Like, are you more sleepy, not just fatigued, but like, are you falling asleep when you don't need to? And when that's happening, or if your partner notices snoring or weird sounds that you make while sleeping, like maybe record yourself while you're sleeping. That can be like a cheap and easy screening. But I have a very low threshold to send somebody to get a sleep study. And every man that I see that has fibromyalgia symptoms, 100% I send them for sleep studies because it's so common. And I've actually like cured a couple of fibromyalgia, referrals, men that were referred to me, and they didn't actually have fibromyalgia. They just had some of the symptoms because they had such bad sleep apnea. They were really fatigued. They were really foggy. They actually were kind of achy because sleep deprivation makes you kind of achy, right? Generates higher levels of inflammation. So I have a low threshold to kind of get some screening for sleep disorders. And then, sleep habits. And then I think there's a couple simple, I would call them supplements or nutritional things that you can do. Magnesium is a wonderful sleep aid. It really helps in fibromyalgia, and it's pretty safe for most folks to take unless you have like a renal, kidney disorder. You can pretty safely add, 200 to 400 milligrams of magnesium at night. And I like magnesium glycinate because it's magnesium and a glycine molecule combined. And both of those are really calming molecules for the brain. So, pharmaceutical options, you definitely need to work with your physician and see if there's, if you have a hard time falling asleep, like if truly insomnia is an issue, that is where maybe some pharmaceuticals might be really helpful. But if you're just kind of wanting to know globally, what can I kind of do to see if I can improve things? I think a trial of magnesium is pretty reasonable. And it's also a muscle relaxant, right? So if you've got some muscle cramping or restless legs type stuff, I think magnesium is worth a try. I think most of us with fibro have have some magnesium deficiency, I would say.
Well, and it's interesting you bring up restless leg because I have oftentimes referred to neurology for restless leg, but I have the pleasure of having a sleep neurologist as opposed to a sleep
Ooh,
pulmonologist
yeah, that's
within
great.
my referral base. And interestingly, again, I haven't done any research on this, but anecdotally, outside of restless leg, we see a fairly high amount of people with central sleep disturbances, such as narcolepsy,
Yeah,
with patients with fibromyalgia. And again, I don't know what the science is behind it because I haven't done any research yet, but I encourage patients not only to look up potential obstructive issues in terms of, especially if you have that significant daytime somnolence, not just fatigue, but like literally falling asleep during the day,
yep,
that ruling out other non-obstructive but neurologic sleep disorders would be of benefit, because it's similarly to you, I've had quite a few patients where, we may have tried a couple pharmacologic interventions, behavioral, physical, but once they got a diagnosis of what was truly causing their sleep
yes,
disturbance, and they got, legitimate treatment from a neurologist for it, it really improved the quality of their lives. So I would just advocate, I think the gist of all of this to our listeners out there is, if you have sleep problems, which again, hard to meet a fibromyalgia patient who doesn't have a sleep issue, whether it's trouble falling asleep, which is insomnia, or staying asleep. There's different versions of insomnia. That talking with your doctor about the symptoms that you're having, and again, whether it's recording how you sound at night or keeping a diary of the instances where you fall asleep during the day, that having that information may help a provider be able to determine the appropriate referral.
absolutely. And most providers, unfortunately, so we have made a lot of progress in the fibromyalgia medical world in that most doctors these days do accept that it is a real condition. So, 20 plus years ago when I was diagnosed in medical school, that wasn't the case. So we made a lot of progress. But I do think that the average primary care doctor who's really giving the bulk of care for fibromyalgia in this country, they understand the pain aspect of fibromyalgia, but they actually don't understand the sleep component as well. And I've definitely noticed that if I can kind of talk to my patients, or that's kind of what I did in the book too, is like, hey, these are things that you might want to bring up with your physician, and you might kind of be helping to educate them a little bit. In my book, I actually have a couple, references for each thing, like, hey, you can print out this article and bring it to your doc about sleep disturbance and fibromyalgia. And so it's kind of my underground way to kind of help educate other physicians, because honestly, most doctors want to help people with fibromyalgia. They just might not know how. And so the sleep is sort of this missing piece, I think, in how we understand and treat fibromyalgia. And I just encourage people to, advocate for themselves, bring it up, do a little self-screening. There's a couple of just simple questionnaires, either online, for sleep apnea, there's ones, or restless legs. Or you could talk to your doctor and say, hey, could you screen me for restless legs? I'm kind of worried I might have it. And that's something that I think a primary care doctor would be like, yeah, absolutely. That's something I can look at and treat. And sometimes they feel so oh my gosh, I don't know what to do for you with fibromyalgia. We've tried the 3 FDA approved medicines and those didn't work. So right.
I did my best.
Exactly. It's I don't know what to do. So it's sometimes you have to a little bit be like, hey, as a patient, sometimes you have to help your doctor help you, because unfortunately, not everybody has access to Dr. Chadwick or, Dr. Liptan, and there's just not enough kind of fibromyalgia expertise out there. So patients have to, unfortunately, become their own self-advocate. And that can be both good and bad, because if you're sort of wandering off in weird parts of the internet, you can get a lot of kind of misinformation and then come into your doctor, and then doctors are like, hey, whoa, what do you mean? That's crazy. Why? I'm not going to recommend that. And that can create this kind of distance. So I think my biggest reminder to patients is remember to kind of stay evidence-based, make sure that what you're talking about or bringing up to your doctor has some basis in kind of science research, not just sort of, I don't know, those oddball
The mystical regions of the internet.
Right. And like weird supplements that, like weight loss
Yeah.
supplements. I'm like, oh Lord, like, 98% of what a patient brings to me as a weight loss supplement. I'm like, this is not a good idea, not enough science. But of course there are some little nuggets of goodness in there, but I think it's important to kind of, and that's another reason why I wrote the book, is I was like, okay, here's what we know, like from a science evidence-based perspective. Even some alternative medicine has really good data. It's just doctors might not know about it. So trying to remain sort of in that data-driven area, I feel like that is helpful.
Absolutely. Now, I'm sure our listeners will want to maybe at least hear us broach the topic of I guess, homeopathic or, stuff that you can buy over the counter. Like what is there from a medicinal standpoint, pharmacologically, that we can provide patients? I'd love to hear what you oftentimes recommend. I think we can probably stay away from specific drugs or doses, but just kind of an outline of maybe some of the drugs that have had some clinical trials. And that way we're sticking within that evidence base for that may help with pain and sleep. That's oftentimes what I like to focus on. I'm sure you have the same dogma. It's like if I can use a drug that will facilitate sleep, but also works on pain mechanisms.
Right. 2 for 1.
2 for.
Yes. Love it. So this is actually where some of the FDA approved medications for fibromyalgia really come into play. So the, gabapentin, pregabalin or Lyrica, both of those actually, in my opinion, have sleep benefit and pain benefit. And so when I have somebody on one of those medications, I usually will have them on like lower doses during the day. So, like smaller doses during the day, and then a little bit of a higher dose at bedtime, because then you're not getting kind of the grogginess or side effects from it during the daytime. But there actually is some data, some good studies showing that gabapentinoids, that type of medicine, actually improves deep sleep. People can stay in deep sleep longer. And so that for me is totally my goal. So I try to like rule out sleep interference, rule out other things that are interfering with sleep, whether it's medications or habits. Try to improve kind of habits around sleep, and then see what we can do from both a natural or pharmacologic standpoint to improve deep sleep. So gabapentinoids, baclofen is actually an interesting one as well that shows some benefit for pain, muscle relaxation, and sleep improvement. So those are kind of the ones that I experiment with there. And then if somebody has insomnia, meaning like can't fall asleep, then I really kind of start with some of the old school, the tricyclics, some of the sedating antidepressants like trazodone, some of those have good data, good safety profiles. And if you can actually, if going to bed is not such a stressful thing, somebody that has chronic insomnia, they look at their bed and they feel fear. You know what I mean? They feel anxiety. So if we have some tool like, okay, I know I can take trazodone and that's going to help me go to sleep, that could make a world of difference.
Well, and it's almost unraveling that pattern of fear and probably even some trauma, surrounding the inability to fall asleep. I mean, it's part of our nature as humans to be, not nocturnal, like we like to be, right? So I can imagine it's very distressing to someone that they feel as if they cannot do a very human thing, which is be able to sleep at night.
Absolutely. I dealt with crazy insomnia in medical school. Like I was so stressed before tests, and this was before fibromyalgia. It just really, my whole life became around like, what can I do to try to get sleep tonight? And then once you're in bed, you're like just worrying. I mean, it just creates this whole level of anxiety that I'm like, if we can remove that, you can get a lot of improvement in fibromyalgia that way,
and it almost retrains the brain to be like, I can do this.
Exactly. Exactly.
I've even told patients sometimes that those medications may not need to be taken for long periods of time.
Right. Or it could just be as needed on nights that you're like, I feel kind of like activated, or I'm stressed, I have a test or doctor's appointment tomorrow. Then the final kind of group of pharmacologic meds that I use are things that tone down the fight or flight response. So that's kind of the alpha blocker type medications. So clonidine is an example, prazosin, a lot of the medications we use for PTSD, and there's a lot of data, a huge amount of data in the PTSD sleep literature. And so I've used a lot of that. And I think fibromyalgia, a lot of patients with fibromyalgia have PTSD or PTSD-like symptoms. And so addressing those with medications to just kind of calm down that fight or flight activity can also be really helpful. So sort of things to improve deep sleep, things to improve sleep onset or insomnia, and then things that tone down that fight or flight nervous system. And then, of course, like you talked about, kind of keeping track scientifically, like, how does this affect me? Or, what was my sleep like, kind of keeping track or presenting it, like gathering data so that you can like know what's helping and what's not.
Absolutely. And I think a lot of people also don't understand how certain just lifestyle things can lead to poor sleep architecture.
Right.
So I always talk to patients about, even the types of foods they might eat before they go to bed. Some people think, oh, I'll have a cup of tea. Well, some teas have high levels of caffeine in them, which are stimulants.
Or chocolate, which has some stimulants.
But a big one that I've talked to my patients about is alcohol, because, we've got kind of a rosé all day society these days. And I think a lot of people enjoy to have a glass of wine when they're consuming their meal. But what we know about alcohol in general is it's highly disruptive of good sleep architecture. And while it may help reduce anxiety or help lend you into sleep, it oftentimes doesn't lead to long-lasting sleep architecture. And then you wake up in the middle of the night and you are anxious because the effects of the alcohol are wearing off. And so it can be a bit of a vicious cycle when people, I do have some patients who are like, well, my pain feels so much better if I have like a couple fingers of scotch at the end of the night, but then I wake up in the middle of the night and I'm right back where I started. And so it's like a fleeting effect, right? So I always talk to patients, I'm not here to imbibe a lifestyle choice on you that doesn't fit with your, potential to have fun or relax or, be social. But in the long run, that type of drug or available remedy is not generally considered to be something that's helpful.
Agreed.
Thank you so much. This has been a great conversation about sleep. I just want to wrap up. I know we're running short on time, but one of the things that we talk about a lot at Swing Care is this idea of multimodal treatment. And often we're talking about that for pain, but I feel like we've touched on that a lot for sleep as well. We talked about kind of the pharmacologic or medication-based approach. And we talked a little bit about kind of behavioral and physical things as well, kind of at the end of the day to build those sleep habits. I'm wondering as we close, as people are starting to think about those sleep routines or sleep habits, if there are one or two recommendations that you have for people to kind of start trying some things maybe on the behavioral or physical side that they can do, but kind of before talking to their doctor or in the meantime, before they have a chance to talk about the pharmacological side.
Yeah, I'll defer to Dr. Liptan first, and then I'll close it out with my thoughts.
Sure. So mine, I'll keep it brief, which is kind of what I alluded to with, treat yourself like you would your 4-year-old kid or grandkid. What are you going to do to kind of help them become calm, have a good routine, and try to establish that and be consistent. Our bodies really like consistency when it comes to sleep. So treat yourself like you're 4 years old.
Absolutely. And I 100% agree. We have medications and physical treatments for fibromyalgia, and some of them may address the sleep and some of them may not. I like to talk to patients about ways to get certain types of things at their fingertips, whether it's an app. For myself, I utilize an app that has preloaded meditations. They vary in lengths from 5 minutes to sometimes even up to 20 minutes. And I use those for myself. And oftentimes they I don't even make it all the way through the meditation, and they're specifically focused on sleep. But I've recommended that to patients, but there's also other digital therapeutics out there. There's one called Stanza, which we use through Swing Care. And within that app, there are chapters and skill sets that people can learn on different types of ways to improve sleep habits and potentially even other types of behavioral interventions for sleep. And when you look at the clinical trials that have been done on Stanza for sleep, about 74% of users who were using it specifically for the effects of fibromyalgia in terms of all of the other symptoms saw improved sleep quality as well. So I think between what's out there in the App Store, coupled with, the things you can do at home, like I said, I love a good bath and a cup of chamomile tea.
Right. Yes.
That all of these things, that are within your home and perhaps in the palm of your hand can generally be helpful. And then having that good physician or clinician provider who's the sounding board and someone who will listen to you is important. And I'm sure you recognize the need for people to have someone that will listen and validate what they're coming to you with.
Absolutely. Absolutely. And I love the idea of having something in your hands. That's just so helpful.
Well, we all live with our phones anyway.
Yeah. It's an additional tool.
Dr. Liptan, where is your phone?
Right here.
Yeah.
Yep.
I mean, this is exactly why I feel like these types of therapies, which probably if you had asked me, 10 years ago or when I was in medical school, would people have potential access to medical interventions on their phone? I would have been like,
no, yeah.
Well, I didn't even get a phone until like 2002. So it's about 10 years ago. But, I mean, it's the absolute, just exponential increase we've had in these types of discoveries, I think is just really great. And as much as I hate my phone, I love my phone. And yep. I bet there's only more to come when it comes to these types of novel and innovative therapies. So hooray for phones.
Yay.
A necessary evil.
Well, thank you both again for this great conversation. I hope people come away with at least a few things they can do starting right away to improve sleep symptoms, and look forward to our next conversation. So thank you again. Really excited to learn more from you and be able to share that with folks.
Thank you.
Thank you so much, Nicole.